everyone, good afternoon. It's now 2 p.m. Eastern Time. Thank you for joining the webinar, Stepping Up in Connections to Care, Making the Case with Data. We'll get started in a few minutes to allow for some additional sign-ins. Good afternoon or good morning, everyone, depending where you are. And thank you for joining us for the webinar, Stepping Up in Connections to Care, Making the Case with Data. My name is Mark Stovall, and I'm a Senior Policy Analyst at the Council of State Governments Justice Center, and I'll be moderating today's webinar. To give you an overview of the webinar today, we'll start with some introductions, including an introduction of the Bureau of Justice Assistance, or BJA, about their support of the Stepping Up initiative. Then we'll do a high-level overview of STEP Measure Achieve, which is Stepping Up's latest call to action to encourage counties to identify targets for the Stepping Up 4 key measures and publicly commit to making progress on these targets. Then we'll hear about some resources available for improving connections to care for people with serious mental illness, or SMI, and co-occurring disorders who are leaving jail. And then we'll hear from Johnson County, Kansas, where they used enhanced identification and outreach and not only increased the connections to care for people with SMI, but also reduced recidivism rates for this population. And at the end of the webinar, we'll have some time for questions and answers. We encourage all of you to enter questions into the Q&A panel on the right-hand portion of your screen on WebEx, and we'll respond to the technical questions as we go, but we'll keep the content-related questions and hold them till the end. And we're also recording this webinar, and so we should have a copy of the recording available on the Stepping Up website by next week. And you can go to the next slide. We're excited to have 4 panels with us today on the webinar. We have Maria Fryer, Policy Advisor for Substance Abuse and Mental Health at the Bureau of Justice Assistance, U.S. Department of Justice. Lisa Haneberg, Deputy Division Director for Behavioral Health at the CSG Justice Center. Rob McDougall, Director of Emergency Services, Johnson County, Kansas Mental Health Center. And Chris Chun Seeley, Program Director, American Psychiatric Association Foundation. Thank you to all of you for joining us for the webinar today. And then I think many of you listening in today are familiar with Stepping Up, but for those of you who aren't, or if you'd like a refresher, Stepping Up is a national initiative to reduce the prevalence of people with serious mental illness, SMI, in jails, and it was started in 2015. And so we just celebrated our 6-year anniversary last month. Stepping Up is a partnership between the CSG Justice Center, the National Association of Counties, and the American Psychiatric Association Foundation. And this slide provides a quick snapshot of some data points for the Stepping Up initiative. So we have over 540 counties now as part of the initiative across 45 states, and we estimate that that covers about 48% of the U.S. population who are living in a Stepping Up county. And the latest national estimates that we have show that about 2 million times each year, people with SMI are booked into local jails. So this really speaks to the scale of the problem that we're trying to address as an initiative. We have 33 counties that are recognized as Stepping Up Innovator counties, meaning that they have accurate, accessible data on the prevalence of SMI in their jails, and they're implementing initiatives and interventions in their counties to have an impact on their jail data on SMI. And 5 states so far have launched Stepping Up initiatives, providing targeted support to counties in their states and helping them with their Stepping Up goals. And so now I'll turn things over to Maria Fryer at BJA for a quick introduction.
Great. Thank you so much, Mark. Good afternoon, everyone. My name is Maria Fryer, and I'm a policy advisor overseeing justice, mental health, and the substance abuse portfolio in the policy office at the Bureau of Justice Assistance, or otherwise known as BJA. Now, at BJA, our mission is to help make communities safer by strengthening the nation's criminal justice system. BJA's grants, training, and technical assistance and policy development services provide state, local, and tribal governments with the best practices they need to reduce and prevent crime, violence, and drug abuse, and to improve the way in which the criminal justice system operates to serve communities. Thank you for joining the webinar and stepping up in connections to care, making the case with data. BJA has been the supporter of the Stepping Up initiative over 6+ years, and we are so excited to share the work of Johnson County, Kansas, and how they increase connections to care for people with mental illness leaving jail, and how they reduce recidivism. We hope that county teams listening in today can take away some helpful lessons learned for their own Stepping Up work. And now I'll turn things over to Risa Hanneberg, who will talk more about Set, Measure, Achieve, Stepping Up's latest call to action. Risa?
Okay. Just doing a sound check. Everyone can hear me? Thumbs up. Thank you. All right. As Mark said, Stepping Up, we just celebrated our 6th anniversary in May, and it was actually last fall that we introduced the Set, Measure, Achieve, the next call to action for Stepping Up, and just a little bit of background on Set, Measure, Achieve before we turn it over to some of the information that Chris and Rob are going to share. But, I think that it's safe to say that after 6 years, actually at the 5-year point, we were discussing that we've had many sites across the country who have been with us pretty much the whole way and making progress. And we're really, I think, at the point of being pushed, if you will, into, what would be the next phase of this work. And so we worked and set out these different targets and measures to work with sites that, generally speaking, to be able to participate in Set, Measure, Achieve, you have reached kind of these, if you will, criteria, thresholds in terms of where you're at in implementing your Stepping Up process. So hopefully you have agreed upon your definition of serious mental illness. You have been able to establish screening and assessment process using a validated screening tool in your jail. In order to ascertain the prevalence rate of the population with SMI in your jail. If you have not actually got that screening in place, you have agreed upon proxy data that will get you to that point, and that you are tracking this information and the breakouts of your population electronically. Next slide. So just a review for what I hope will be a review for most of you on the Stepping Up 4 key measures, because this is what really drives the Set, Measure, Achieve work. And that first measure is to reduce the number of people with mental illness booked into jails. The second measure is for those who do come into jails that you want to shorten that average length of stay for that population who have serious mental illness. Generally, when we go in and work with a jurisdiction, we do see that the population with SMI tend to stay in jail, have those longer stays, up to maybe twice as much or more as the general population. The measure we're going to really focus on today is Measure 3, and that's increasing connection to treatment, supervision, the services in the community at discharge. And then the fourth measure is being able to track and demonstrate recidivism, which for stepping up we define as a rebooking into jail. Next slide. So why set baselines, targets, and track data? So, very simply put, baselines tell you where you're starting from, and so you want to be able to set those baselines first and foremost on that prevalence rate of the population in the jail with SMI. But ideally, you would be able to set baselines along all four of those four key measures. So you would want to have a baseline as far as that prevalence rate, the number of people being booked into your jail with SMI for that population, their average length of stay, your level of, your rate of connecting to care at discharge, and then being able to track the rebookings of that population with SMI. So once you would set those baselines, then you could start to have those discussions there in your community with your planning team, with your stepping up group there in terms of looking at what your rates are, what your baselines are, and we'll probably encourage you and guide you as to where you maybe want to set some targets and what strategies you would then line up to be able to show the changes. Tracking this data, will inform your progress or lack thereof, so you can have those discussions around, what's going on, why aren't we making improvements, et cetera. And I think, if you will, and I think we'll hear about this from Johnson County today, the bonus in all of this is that being able to, be able to have these measurable outcomes, be able to tell your story based on data, because in many cases been able to provide justification for your programs, maybe substantiating needs for expansion, and being able to work through your sustainability planning. Next slide. So just before you're getting started on tracking your outcomes and where you want to go with set, measure, achieve, some of the questions that guide your process is, first of all, when did your county start tracking SMI? So setting that initial baseline of prevalence rate. And then in a perfect world, you haven't already started any new policies or program implementation. I know that's not always the case, but you can see how if you set your baseline and then you would start a new project, program, change a policy, you really have a nice way of comparing your changes. And then also right at the onset, you want to set your time period. So over what period of time did you collect your data to base your baseline on? We get asked this question a lot. What does it take to be able to say, yes, we're going to go with this number? But you just generally, we've had sites that do it for 3 months, 6 months, maybe even a year. Some look at number of cases, at least, 500 cases, something along those lines would give you some good feeling that you've set and been able to establish a baseline. And then you want to set your baseline period after that SMI data collection was started, as I said, but before, if you can, you're making some sort of changes in your policies and practices. Next slide. So I'm going to just go through these particular targets that we, through Stepping Up, have set forth. They are not anything that's required. They're suggested, but, just as a starting point. So if you were going to, first of all, look at, reducing the number of your average daily population with SMI in your jail, we have suggested that you set a goal of a 5% reduction over a period of 3 years is what we're asking our sites to track this for. And you can just read through there, 10% if you're looking at reducing the annual jail bookings number, 5% annual reduction in average length of stay. So, we have sites across the country that we know are participating in Set, Measure, Achieve. They haven't necessarily followed these exact suggested guidelines, but, I think the important thing here is that you've set your baseline, you've decided on, which are all of the measures that you want to start tracking for improvements and at what level you want to be able to demonstrate those changes. We would love, as a part of Stepping Up, that you announce your participation in SMI so that we can work with you. We are hoping to be able to build more of a national level story in terms of the movement and the progress that's being made across the country. Next slide. So as I said today, we're going to concentrate on measure number 3, and that's increasing your connections to care. I just, as a review, going to talk through, collecting and tracking this data. I just want to say that we have this detailed kind of directives put in place in a separate brief on Set, Measure, Achieve that goes through all of the measures and the data to track and how to go about doing that. So let me just say at the onset, I think tracking connections to care can be one of the most difficult of the 4 key measures because of the fact that once that person leaves the jail, many times we lose them, right? Or if they've left the jail where all the data is neatly stored in the jail management system, they've now crossed over to your local behavioral health provider, which is a whole different data resource and information system that is not necessarily easy to make those matches, track, and know that this same individual who left the jail is the same individual who is now in services at that facility. So for Stepping Up, we basically are encouraging that you continue to rely on your jail management system, that you work with your jail administrators in creating in the JMS a way to track that at the time of discharge, the efforts have been made to ensure that that connection to care is planned out and going to ideally occur. We know that this is a perfect world, but we wanted to at least have a way of being able to include as many sites as possible across the country to track this particular measure. For those of you who have worked through all of those difficult decisions on sharing information, accessing other information systems and data sharing and so forth across systems, that is wonderful, lovely. Please continue in that process. But otherwise, once you work through all that, it's generally like a yes or no. Yes, we've made the connection. Yes, the person's engaged or not. I'm going to let Chris talk a little more in detail about that definition of engagement, but that is something that you would want to define in this process. Next slide. So I mentioned earlier that whatever measure that you're setting a target around, that it's important then that you line up a strategy that aligns with that particular target. So since today we are focusing on measure number 3, the connections to care, you can see under on the graphic here, the column under measure 3, some of the ways that if you implemented any one of those strategies there that are just suggestions, there's other ways of going about this, and obviously we're going to feature what Johnson County has done today. But what is important here is that if you're setting a target, and then you decide on what your policy change, your program change, what you're going to implement doesn't line up with that target, you can't expect to move the needle on that particular measure. So, to really think through that, we want to increase connection to care, we want to, reduce the number of bookings into jail, but the different interventions are matching, where you are wanting to make your changes. Next slide. All right, and I'm going to now switch over to Chris. So thank you, everyone.
And thank you, Risa. And I think you set me perfectly up to talk about the difference between connection to care and engagement to care to start out with. And I think what I really want to emphasize with everyone listening here is that your role or responsibility is to give them the option of that connection to care, is to, as many times as it may take, and sometimes I talk with that, sometimes it's 15,000 times that you might have to walk that person to the services before they actually cross that threshold and engage in those support services. And, you can never make somebody engage in that connection to care. What you can do is just always continue to offer it. And if you can go to the next slide, please. What we really want to, I think, encourage everyone to think about is these 2 main questions to really drive decision to care. 1, did that person make it to their first appointment? and 2. So these may seem like very simple questions to start with, but they are actually very, very complex questions. There is so many differences and so many variations and factors that come into play with every community that we really need to dive a little bit deeper into figuring out, did a person make it to their first appointment, and did they like the provider and feel engaged? But we really need to start somewhere, and that really starts with thinking about your state and your local community, and how does funding come in? How do you provide support for these individuals? And then it goes to partners and finding the right partners. And I know we're going to hear at least a little bit later on from Rob about a partnership that they were able to put together. But it's about finding the right partners and also addressing those additional barriers to care, right? We know it's not just mental illness most of the time. There's also housing, there's transportation issues, there's a slew of things or barriers or obstacles that these individuals might have to get through before they even think about making it to that first appointment for their mental illness or their substance use. So we really need to make sure that we are, I think, taking an effort whenever possible to try to shift the conversation from these individuals being criminal and being able to stop their criminality to making sure that we understand the role and the aspect of these individuals as community members, and shifting and making that shift happen so that when we think about helping this person, it's not helping a criminal or helping this individual with SMI, it's helping this community member and trying to get them re-engaged and become the most productive self for themselves. Next slide, please. And so in an effort to do that, what the APA Foundation is currently working on is a Connection to Care video series. And I wanted to tease just a little bit here and talk a little bit about it and really make sure that explain that this is going to be a video around a candid conversation between psychiatrists, county officials, jail providers, and others involved in the jail system, really to provide a guide on how communities can address connection to care for our community members suffering from mental illness. The first video will focus on those two main questions. Did that person make it to their first appointment, and did they like the provider and feel engaged? And as I said, it's a very complex question, and it's going to be a lot of small little questions that you're going to have to look at and answer. And what we're also going to do as a part of that video series, for each of there's 8 questions that kind of fall under those two main questions that we really want to help communities ask the right questions, find the right answers, and then develop a plan so that they can really make sure that when someone does leave the jail doors, as Risa said, is that they make that connection. They actually make it to that first appointment. When we do find the right provider, that they are right for that individual, whether that's from a rural aspect or from a location aspect, really making sure that we take the time to understand where these services are and how a person may access those services. We're really excited to get this resource out into the field and are looking forward to actually creating more of these candid conversations and producing more of these videos and resources as we look at partnerships, right treatment plans, thinking about AOT and some of these other mechanisms for diversion that have been put in place, and how do we make sure that we're using it correctly. Next slide, please. So just wanted to share 2 quotes with you. The first one here, the use of long-acting antipsychotics and long-acting opioid addiction treatments can have profound impacts on your patients staying stable while they're working hard on navigating the system. So again, this is kind of being pulled from understanding the barriers to accessing treatment and what can you put in place to really help them navigate this very complex system. The next quote actually came about when we were talking about this idea of creating a system that's focused on connection to care outside of punishment. And our psychiatrist, Dr. Hurley, quoted that this benefits everybody, not just the individuals who are justice involved. It prevents crime, it prevents victimization, and it helps support the health and well-being of the community as a whole. And I think that's what we want to do when we're thinking about this connection to care and the Stepping Up initiative as a whole, is really making sure that we're benefiting everybody and we're making a system that makes sure we're getting not only people who are connected to care, but make sure they stay connected to care. So I just want to continue to encourage everyone to really push forward with this connection to care measure, especially within Set, Measure, Achieve. And I'm really excited to share with you and let everyone else hear about the great work that Rob from Johnson County Mental Health Center has been engaged with. So I'd like to actually pass the mic over to him so that we can listen in on the great work that he and his team have done.
Thank you, Chris. I appreciate it. I took a little tidbit actually from your presentation about those questions I found pretty interesting, and I might refer back to that here a little bit later in my presentation. Chris, if you could go ahead and move to the next slide. Just a quick introduction. My name is Rob McDougall, and I'm Director of Emergency Services here at Johnson County Mental Health. Johnson County Mental Health is a community mental health center. We fall within county government within Johnson County. I think it's kind of important context in terms of the community mental health work that we do, and then our connections with particularly our county jail and other county agencies, especially with respect to data sharing. Johnson County has about a population of just over 600,000 individuals. We are one of the 4 core counties of the Kansas City metro area. We sit roughly in the southwest quadrant. And are primarily a suburban community, suburban county. We'll go ahead and go to the next slide. So today, what I'm going to go over and talk about is a program that we call our Brief Jail Mental Health Screen Outreach Project. Talk about how we utilize that tool and it evolved into work to both kind of cast a wider net for at-risk individuals, but also increase their connections to care with ultimately the goal of decreasing recidivism. I don't know that we necessarily saw that end when we first birthed the idea, if you will, of this project, but it evolved as such, and we ended up having a really unique and fantastic opportunity to have the project evaluated by Notre Dame's William Sheehan Lab for Economic Opportunity, which ended up showing positive results. So we had some pretty, very, actually from my perspective, surprising results in connecting individuals with care and then ultimately impacting recidivism. It has definitely, this project has definitely helped us kind of oil conversations about further collaboration and really business partnership in many ways with our sheriff's department, and has us looking to the future for some other projects to include medication-assisted treatment and a more formal reentry program, a more formal and deliberate reentry program. Okay, Chris, go ahead and go to the next slide. So back in 2016, our then criminal justice coordinator, his name was Robert Sullivan, he had been working post us joining the Stepping Up initiative in 2015, was working to try to find a mechanism to get better data on those suffering from mental illness entering into our jail. Landed on using the Brief Jail Mental Health Screen tool. For those of you that aren't familiar with it, it's an 8-question APA validated tool developed by Policy Research Associates. And it's meant to flag individuals who are at risk of mental illness. It's not meant to be a clinical diagnostic tool, but simply to flag risk, and then from there you can make your decisions on how much more of a clinical intervention or interview you want to do, or what projects can derive potentially from that information. So one of the beauties about the Brief Jail Mental Health Screen is it can be, those questions can be asked by a layperson. It doesn't need to be implemented through a clinician. So that keeps that information outside of the umbrella of HIPAA, and I think can make it easier to communicate with the data for sure, but also I think within the criminal justice community, a little bit easier to communicate to in terms of flagging folks that are individuals that are higher risk of mental illness. So Robert was able, through a lot of political work, I'll say, was able to convince our sheriff at the time to add the Brief Jail Mental Health Screen to the booking tool. This was it took about a year of convincing, kind of make a long story short. And in November 2017, it was officially implemented. And at that point, Robert had approached me and asked if there's some way that we can use the brief jail mental health screen to both identify, but then also intervene in a way that could be helpful and maybe bend that curve of recidivism, or at least help to work to connect people with needed resources. So definitely was excited about the opportunity. We work in a culture here at our organization of trying to do the best that we can to embrace innovation and figuring out ways to do things. And as we went back and talked a bit, really liked the opportunity that the brief jail mental health screen both gave us in terms of casting that wider net, but also the opportunity to connect folks to services, whether it's ourselves or in the community, reduce recidivism, and then ultimately the reality for us in committing and doing something that was going to have to be without new resources. So trying to be creative and figuring out where I had capacity and within my bubble of responsibility to do something. So with that, I've got one of my teams mans a 24-hour crisis line, and my evening staff, not non-business hour staff, did have some capacity to do more phone work. And so what we landed on was that my evening mental health center clinicians, or master's level clinicians, would receive referrals through a database, or Justice Information Management System, JIMS for short, within Johnson County, and would receive referrals. And then once that person was released from jail, we would make 2 phone calls attempts within 72 hours. Now, there were times, a very small percentage of folks that we would outreach face to face. We would go knock on the door and attempt, and we would make those decisions based usually on information that we had from other sources on maybe acuity of mental health issues, history of mental illness, and the lack of being connected to resources. I need to also, for more context, at this particular time in 2016 to in 2017, Johnson County was contracting with a private provider within our jail to provide behavioral health services. So our goal with those phone calls was to say, hey, this is a caring person. I'm giving you a call. There's a little awkward to say, yeah, we knew you had some contact with the criminal justice system, but we were wanting to partner with you to try to figure out what we can do to help connect you with the resources to avoid contact with the police and our criminal justice system in the future, which the vast majority of the time we received very positive feedback from individuals. Did not get a lot of slamming the phones down and such. People are willing to align if you're there to authentically help. So we started that project. We started those phone calls in March of 2017. So go ahead, Chris, we'll go to the next slide. So in moving about a year into the project in 2018, we were doing the work, but not really sure whether we were having an impact. And we were actually having a conversation at that time whether, how can we figure out a way to measure or sort out if we're having an impact. We were collecting good data, but we didn't have any mechanism or person within our organization that could evaluate that information. So in and around that same time, I had a peer that was presenting at another conference in which there was a representative from Notre Dame's William Sheehan Lab for Economic Opportunity. And my peer had talked a little bit about the work that we were doing. It had the presentation had more to do with data sharing within Johnson County government. And this was an example of some of the benefits of that this project was an example of some of the benefits of data sharing. Well, the LEO, the Notre Dame LEO representative expressed some interest. We ended up connecting in the summer of 2018, and the Lab for Economic Opportunity agreed to evaluate this program. The William Sheehan Lab for Economic Opportunity is a research arm of Notre Dame that connects programs that have what appear to be a promising impact on social justice, poverty issues. And they will provide free evaluation. You have to go through an application process, but if they believe that there's promise there and you've got good data, they will provide free evaluation for that project. So we were very, very fortunate to kind of happen across the opportunity, and very grateful to this day. So what were we trying to measure? Ultimately, were we successful in making contact with folks, outreaching? And the way we were measuring that success was comparing recidivism and connection results between non-residents of Johnson County and Johnson County residents. Now, just again, to give you a little bit more context, our jail, we're part of a large metro area. And so about half of the individuals who are arrested and booked into our adult detention center are non-Johnson County residents. Being that Johnson County Mental Health Center is part of county government, we were focusing our outreach efforts on only Johnson County residents. So at one point, as Notre Dame began their evaluation project, they came back with some preliminary results in 2019 that were showing positive impact on bending that recidivism curve for Johnson County residents. Now, recognizing that we're in a large metro area and wanting to pay as much fidelity or consistency sort of to the definition of recidivism, Notre Dame was asking, well, is there a way that we can look at the surrounding communities or surrounding counties so we can get maybe a more accurate idea of recidivism, knowing that Johnson County residents go to Wyandotte County or Wyandotte County, Kansas, or Jackson County, Missouri. And so we said, yeah, let's give it a shot. Notre Dame actually took that part of the project on. They reached out to both county governments, and as I'll talk a little bit more later, were successful in getting data agreements signed and getting booking data from both of those communities, and eventually later on to the state. In summary, Notre Dame found that we were successful in connecting with a lot of people and connecting them to resources based on our definition of connection, and that we had a positive impact on recidivism. Chris, if you go ahead and go to the next slide. This is a brief map it's a zip code map of the 3 counties, and the shades of blue shows the population density of the individuals that we were following, what zip code they either were from and or compared to with this project. As I said before, it was only provided to Johnson County residents, and that the evaluation time period too, I want to be clear, was March of 2017 through May of 2020. We had some pretty significant changes in jail staffing, which I'll talk to towards the end, and was a part of a result of this program in which we do outreach significantly different now. I'll go ahead, Chris, to the next slide. So as I talked a little bit about the expanding of who we were taking a look at, or what jails we were taking a look at in the area, the Lab for Economic Opportunity was able to finally put gather all the data for them to do their evaluation by last winter of 2020. It did take a while. I mean, as you can see on the timeline up there, it took about 1.5 years for them to be able to get the agreements together and gather all of that data. Chris, go ahead and go to the next slide. So just to give you a little bit of numbers, like I said before, we made 2 phone call attempts, almost all phone calls within 72 hours. In that's May to 17 to July of 20, we had 5,818 referrals. We were able to successfully contact 44% of those. That's not necessarily a large percentage, but I do feel pretty good about that, in that we were reaching, cold calling people after they were released from jail. So at that point, we weren't able to make contact with that individual in jail. So folks go a lot of different directions, and phone numbers change, addresses change quite a bit with folks that are struggling with serious mental health issues and having contact with the criminal justice system. Now, of those 44%, we were successful in connecting about 28% of those individuals with services. Now, what does that mean? It's not as clear-cut of a definition as what Chris had defined. I really like the two questions that Chris had indicated earlier, and in hindsight, I wish I would have had that information from the get-go. We would ask somebody if they were, kind of explore what the needs, ask them if they had existing services, clarify if they had appointments scheduled, and if they did and they felt confident and engaged, then we moved on. If they did not, we would make referrals to them, and we would do a follow-up phone call within a week or two to see if they had made some contact. We didn't do clear tracking of those follow-up phone calls and the success rate at that point. But we have more opportunity to do that, I think, moving forward. And then there's also a decent percentage of individuals that we brought into the umbrella of our services. Now, our agency is focused on serving individuals with severe and persistent illness, kind of the most sick and the most acute. So not necessarily everybody, but certainly we're able to get a healthy number of folks engaged into our services. Now for the recidivism results. Chris, if you could pop over to the next slide. So again, when we first started this, it was yeah, hey, we'll try something, and oh, awesome, we're doing something now, and we have this fantastic institution willing to evaluate. Didn't really think critically enough at that point to sort of set goals or even feel super optimistic that we're having a large impact on reducing recidivism. So these results, when we got our evaluation information, they came back, were highly and pleasantly surprising. So in looking 60 days out, post-release, 180 and 360, so almost a full year, there was a 12-point percentage drop for individuals in recidivism for individuals that we had made connections with through our outreach process. 180 days, it continued to see a drop at 10%, and then after 360 days, a 9% drop. Chris, if you would go ahead and go to the next slide. Digging into some of that data, with the brief jail mental health screen, there's a question or two that asks about if a person has been in previous mental health treatment. So at the 60-day interval, as I already indicated, we were successful in achieving a 12-point drop in recidivism. If a person had been it indicated they had been engaged in treatment before, were taking meds, or had been in the hospital, that was an 11 percentage point drop. And then probably not shockingly, but it was very validating for individuals that indicated risk but had never been engaged in any sort of mental health treatment. We had a huge impact, and that was a full 23-point drop. And these were probably the individuals that we were even more assertive in trying to make sure they were either connected with somebody in the community or connected with us. That's a perception, not a evidence-based. I can't put a number to that right now. You can go ahead and move to the next slide. So moving forward, this journey with the brief jail mental health screen and the outreach project was part of kind of oiled a conversation that we were having with our sheriff's department about taking over services, behavioral health services within our county jail. And we were successful in creating that partnership. And beginning in January of 2020, so right before COVID, of course, we have it's called our justice team that's composed of a team leader, several clinicians, case managers, a prescriber, and then a few nurses. And we're now providing the behavioral health care within our jail. It tickles me in many ways, in terms of my many years of work in outreach and engagement efforts. I can say with a great deal of confidence that being able to meet somebody and trying to engage with them face to face has much more weight and odds are a better end in engagement than a phone call. And so now we have staff in the jail that are outreaching individuals identified at risk by the brief jail mental health screen prior to their release. So we've already seen a massive increase in the contact rate. We don't have quite yet data on the connection to services and such, but I do feel pretty confident that that will look better too on our end. We are also applying, we've applied for two SAMHSA grants in conjunction with the Sheriff's Department to add a reentry team, that'll work pretty closely with our corrections as well as the jail, which that will take the kind of warm handoff, whether it's us or to community services, to a whole other level, kind of going back to the questions that you were talking about, Chris, where we can actually say, hey, we walked this person to see this provider in the community, and yes, they are engaged, they like it, they feel like they're getting their needs met, and so on. So I had hoped that the evaluation from Notre Dame would be positive, and I could use that to make an argument for more resources. That happened before we had the evaluation, and the partnership that had started between us and the Sheriff's Department helped, like I said before, to oil that process or that opportunity. Go ahead, Chris, the next slide. So just in summary, we've been successful, connecting through this project, just the phone, primarily phone outreach. About half of the folks that we had reached, we were able to reach about half the folks, and then about a quarter of those individuals were able to confirm that they were connected with some sort of mental health services. We were successful in showing a reduction in recidivism over time, particularly those without prior treatment. Notre Dame's William Shim Lab for Economic Opportunity has put out a two-page policy brief. They are working on an academic research paper right now, and hopefully we'll, I know we've had a draft of that floating around a little bit. Hopefully we'll see that here before too much longer. And I believe that ends my slides, Chris. I think the last slide is questions and answers. I have not been focusing very much on the chat, so forgive me for that, and I might use some direction or guidance if there's questions that pop up.
Rob, it's Risa. I'm going to rescue you.
Thank you.
Yeah, but don't go away. You've got some questions. So I just, I think many of you know that Johnson County is my home jurisdiction. So excited for, me on a personal level to see all this great data and the work that's continued to go on since I left Johnson County. So a couple of things that have already come into the chat, Rob, and one thing that you didn't cover, and I don't want to put you on the spot here, but do you have any plans to implement AOT, assisted outpatient treatment, or where are you at on that one? And also, Chris, if you want to chime in too.
We do have an AOT program. It could use an injection of deliberateness, if that's a word. We've had a mechanism for outpatient treatment orders in Kansas from per the care and treatment statutes for as long as I've been in the profession, 20 plus years. And so we've always had individuals that will come out of our hospitals on outpatient treatment orders if they had gone in involuntarily, and they, within Johnson County, have to receive their services through Johnson County Mental Health, and we would do reports and such to the court. So it was what we were doing was a loose AOT program. We had formalized it where we actually have a full-time staff that part of their responsibility, clinician, is to that AOT program and coordinating treatment regarding the clients that are on it. I think we still have some work still to do. And I could talk more about that if somebody wants to talk about it individually. But
Chris, do you want to, I don't want to put you on the spot either, but I don't know if you wanted to share anything about AOT services.
I would just, yes, I would encourage people to think about using them, but if you're already using them or thinking about it, also make sure that the access to AOT is equitable, as well, because sometimes, we can see that in just access to diversion services sometimes aren't available to everyone in the population. So making sure you kind of take that just as you're thinking through those services.
Yeah, it takes a village. We as a community health center are very motivated with our AOT program. Our judge, our current care and treatment judge, is fantastic, fantastic partner. He's also very motivated. Our DA's office has been probably, honestly, a bit lukewarm, and that's where we have some room to grow. And then we have a state hospital that a lot of these individuals are coming out of on treatment orders, and it's outside of our community. And they're pretty resistant to putting people on treatment orders. I think a lot of times they see it as increasing the risk that the person will end up back at their hospital because of a revocation of the treatment order or whatnot. And we've had some recent conversations with them. I've offered to go down and bring some of our staff and present, because really in the end, AOT is shown to decrease hospitalizations. And that's ultimately what our goal would be, along with a civil alternative to the criminal path in the justice system.
Thanks to both of you. I think probably a question again. Both of you can go for this one, but I'm going to paraphrase this question. But it's around it's a situation where you have an individual who then is showing progress, and you maybe even, if you will, kind of downgrade their acuity level in terms of their mental health needs, and then many times they may even get closed out of services. I mean, just what is your response to when is the right time for that? And especially when we're looking at, we don't want a person to relapse or re-enter the justice system, et cetera. So both, Rob, if you want to take it first, and then Chris.
I mean, we don't really have like a kind of a clinical measure or a tiering on when we would stop working with somebody. I don't want to go get too wordy, Risa and all, because I know Risa would know that I can give too much context. But within Johnson County Mental Health, we serve about 10,000 individuals. We're focused on those with severe persistent mental illness. So if somebody's severe and persistently mentally ill and has that criminal justice contact, then they're going to move into those services. Within my bubble and emergency services, I say we serve 600,000 plus individuals in Johnson County. So I have case managers that will work with folks that maybe don't meet that SPMI criteria, but have had a lot of police contact or are coming out of jail, and we'll work with them for a period of time until there's a mutual understanding of stability and the person's got a solid foundation under them. Sometimes that might only be a couple, 2 or 3 weeks. Sometimes that might be upwards of 6 months. It just kind of depends. The other piece too is we have a very close relationships with our law enforcement, and we've got clinicians embedded with our law enforcement agencies. And so when there's contact with folks that maybe we had worked with in the future, we will usually hear about it or have a chance to intervene in that moment that law enforcement is having contact again. So that gives us a point right there to engage, maybe even divert them to treatment instead of jail, depending on the criminal context or the type of contact and such. And then re-engage them with our services, again, depending on the details.
Thanks, Rob. Chris, did you want to add anything to that question?
Yeah, I think as a social worker, what I would say is that you never want to stop supporting these individuals. I think the level of support obviously needs to shift and change, on your resources and everything. But that's why I think personally, peer support is so important. So if you can put together a peer support network where that person is now connected to a new support community who has similar experiences, sometimes especially with SMI, it's a lifelong journey. So I think also looking at if you have a local NAMI chapter that you can partner with to maybe make a support group for individuals that have justice involvement and this mental illness. I think that's I don't think you should ever stop support. I think you should always evolve what the supports look like in your community.
Thank you. I think that's great advice as well, and we certainly are seeing, I think, more and more bringing peers into the planning and programming for this population. So thanks for pointing us to that, Chris. Chris, could you go back to, I think it's slide 17? Sorry, I didn't warn you about this. There. Oops. Go back. Rob, it's the one that has the data about at the end the connection, like the first 60 days?
So I think that's 27, well, or
Okay,
26.
Perfect.
26, there we go.
Wait, so, okay, actually, this was something that crossed my mind when this slide was up. And I've seen, I'm not making this up, but I've seen data around how crucial the first 60 days are after discharge from jail. And so to me, this points to, that's where you saw some of your largest success in increasing and reducing recidivism. And I don't know if in Johnson County you've pulled your data as far as general population and how quick they return on a booking versus the population with SMI. And where I'm going with this is just, I think to all of the folks who are listening in today, just how important those first 60 days are, even probably the first few days. Like you said, 72 hours is where you landed, Rob. And, I just didn't know if you maybe wanted to just, before we close out today, focus a little bit on, how important just those first few days after release are.
Yeah, I totally agree with you. I think that for a lot of folks, I'm probably preaching to the choir, they going into jail can be a massive interruption in anybody's life. It can threaten job, childcare, relationships, paying certain bills and rent, your utilities, and so on and so forth. And then if you mix in somebody that's struggling with severe mental health issues and they already have the capacity problems in dealing with some of your daily function, that's just coming out of jail is a super point of opportunity to try to help put a bit of as firm of a foundation underneath the person that they're not losing some of those key basic needs like housing or they're not having to help them sort their job situation out if they are employed and so on. I hadn't probably given it as much critical thought, Risa, paying attention to that first 60, but our movement towards wanting to have a reentry team where, we've got the case managers that are working to engage in the jail, but we don't always have as quick, ideally that reentry team will meet the person as they're being released from jail, help make sure that they've got their needs met that particular day, and then are working with them more intensively, certainly for the next couple of weeks to help make sure they're meeting all those, their basic needs are met, but then also that they're meeting the court's requirements so that they don't end up on a spin cycle of missing court, not getting a particular fine in on time, and the warrants that come with that, and so on and so forth.
Thanks.
Does that help answer your
Rob.
question, Risa, a bit? Or
Yeah, I just that really rang a bell with me, and I also just saw Maria also added in that the first 60 days are extremely crucial for co-occurring and substance use, relapse, et cetera. So, I just kind of wanted to underline that for everybody listening in. I also want to underline that, Rob pointed out that they did this with no new staff, and they just found a way to really maximize some of the, I hate to use the words downtime, but I think you said capacity. When you had staff that, could do these extra phone calls and so forth. So, I think that's always, I'm surprised we haven't gotten that question today, like how did you fund this, or, how are you going to sustain it? But, I don't know. And then I think wrapping up, Rob, one of the questions was, how would you go about making this better and trying to increase your level of engagement?
Yeah, well, before I go to that question real quick, Risa, I want to go back to the substance use. That is the next step for us. As far as progress goes, we're not capturing a picture of individuals that are struggling with substance use disorder, whether that's primary or co-occurring with mental illness. And we've talked about trying to get the expert as part of the booking process. So that's a place where we definitely have this experience. I hope feeds into that conversation of saying, hey, look what we're able to do. Can we consider putting the expert? That's what we've talked about as far as the tools go, but a tool to hopefully flag for substance use risk. The things that it could do to make it better, early on, I mean, we had an application that ended up a referral application that ended up being tweaked considerably to help us in our workflow and tracking data. I think we were very fortunate that we had a data group, part of the GIMS Justice Information Management System that I referenced earlier, that had the ability to sort of create this application for us. That was a place that we had tweaked a lot early on. I think that once we got to a point where we were pretty confident we were having a positive impact, I mean, ultimately getting to a place where we could be in the jail and having face-to-face contact with folks instead of trying to track them down by phone afterwards. That was a goal, 2018, 2019-ish for me. In fact, we had applied for a grant, a state grant in 2019, and were awarded it, but we had to decline it because it was only like basically half the amount that we would have need to have added 2 case managers into the jail for this specific purpose, to outreach folks face to face. So if there's any way that if you have a connection with folks that are providing the services in the jail, would be willing to use this tool to help kind of cast that wider net. I will say, I won't name the name of the company, but our private provider that was providing behavioral services back in 2016, we approached them about using this data and this information to reach out to a broader spectrum of folks than they typically would, and they were not interested. They're a private organization. It would have required more work, wasn't part of their contract, so on and so forth. At that time, a frustrating piece for me and my staff on the outside was, they tended to be hyper focused on suicide, that kind of high liability issue for jail and suicide prevention, which I certainly get that. But we would have a lot of individuals that had psychosis, or would have a mania coming in, or would be close to self-care failures on the depression side, that we're not getting the same level of intervention going into jail, but then also at the point of discharge too, where the brief jail mental health screen gave us an opportunity to connect with some of those individuals.
Thanks, Rob. And just a couple clarifications that I think our conversation has maybe triggered. And so do you try to connect with everybody who did screen positive on the brief jail mental health screen, or do you have, kind of a decision tree there?
No, we work to connect every single Johnson County resident. So every single person has a Johnson County address that indicates positive.
Positive. Okay, that's what I thought. And then another question was definition of recidivism. Is that rebooking into jail? And
yes.
You're looking at different intervals, obviously 60 days, and the numbers that you've already shared today.
Yep. Yeah, we carved out, like, we would have some individuals that would get booked because before they were being transferred to like prison sentences. So we would carve them out. There was a way to code that out. But it was, as far as the definition, it was folks that are rebooked.
All right. I think I have been able to work through the questions that have come through in the chat box. If we have not, for some reason, answered your questions, our contact information is at the end of the presentation, and feel free to contact myself, Mark, Chris, but I just want to kind of wrap things up here for everyone today, and just really, thank particularly Rob and all the work that's going on there in Johnson County, and everybody else who was on with us today. But most of all, thanks to all of you who joined us today. And again, I hope we have in some ways helped you in your planning and your efforts. Oh, I think I have one more popped up here. Let me see what I've got. Can somebody shoot me the question? Came from my friend Rick Kagan out of Kansas.
Hi, Rick.
Mark, do you see the question?
I'm just trying to pull it up here.
Okay, go ahead and just say it, Mark, if you want to.
Or actually, I can't find it now.
Okay. All right. I'm not sure we can get to it, but again, we'll follow up with you after the webinar today and get that answered for you. All right. Again, thank you to all of our panelists today and everybody. Best wishes, stay safe, and thanks again for joining.